I have a very different story. Not being I'm not a life scientist or a health systems researcher, and I fundamentally come out of the policy world. I was here, long enough ago that I was here when HIPAA was written. So, and what I've been interested in is the way that we can use technology to affect policy, and use policy then to affect the technology in return. So 8 years ago, I started working on informed consent in the digital context. Looking at, in particular, the way that we sign agreements without paying attention to them. This is one of my favorite sociological studies in which people gave away their firstborn child in return for free Wi-Fi, because no one reads the terms and conditions. And this is a fundamental problem as we begin moving towards the golden age that Hardeep wants to get us towards, is if we're going to use phones, we have to accept the fact that people click OK on legal agreements between them and their goal. And this presents enormous problems culturally for simple consent, but it creates significant problems for informed consent to enroll people into medical research. One of the core benefits of a phone supposedly is that we will use them to enroll people. But if we know that people are socially conditioned not to click without reading, then we have to address that. This is not the kind of thing that NIH is good at funding. I work at a nonprofit organization that gets most of its funding from NIH. This is not a kind of project that leads to papers as naturally as a classic piece of R01 research. And so thanks to AHRQ funding the Electronic Data Methods Forum, convened by Academy Health, we received a small grant as well as in-kind support to do a really unusual project in which we did classic commercial style product design, which is to say ethnographic interviews with key stakeholders, user experience design and interaction design, looking at the problem of informed consent on a mobile device. And what we found is that everyone knew what the problems were with traditional consent, which is that we hand people documents written at a 25th grade level that are 25 pages long, and we give you 30 seconds and encourage you to just say yes because you trust us. So everyone knew that was a problem, but no one knew how to change. But there was a lot of support for this kind of design approach because it hadn't failed yet. And it didn't conflict with anyone's local incentives because it could sit on top of whatever your document was and create this interface. There's another problem when you do device-based reading, which is that people physically don't read the same way on screens that they do on print. So this is known as the F pattern, and if you look at languages that read right to left, it's a F in a mirror. We read across, down, across, and we read less and less text as the screen goes. So even if you were to present the document and someone were to stop and read it, they wouldn't physically read all of the words, but they would think that they had, right? So this is where I make a joke about culture, politics, and everything in the world right now. But it's really problematic when you're going to try to enroll people into a clinical study. And so what we came out of this was not an academic paper, but a set of designs. And this is not, again, what a traditional kind of funding stream creates. It's sort of the uniqueness of the ability of AHRQ to fund, and in particular fund into secondary groups like the CORI and EDM that can then make these kinds of bets relatively quickly. So could we create designs that slowed people down so that we could plausibly claim informed consent on a phone? And this is what came out of the AHRQ funding. I did this in PowerPoint, which is why it's ugly. But the idea was if you're going to enroll in a mobile research study, we might want to know things like, what's your gait like? And we would use the same sensors that you would use to turn your phone from landscape to portrait to do that analysis. So the idea was make someone do that on their phone as part of a consent process. We released all of this as open source because this is government money and this is the right thing to do with taxpayer funding. And Apple picked it up. And so this is now baked into Apple's Research Kit, which is an entire app-based framework for building apps for research studies. It's been used by at least 60 major research institutions in the United States, and it's enrolled about 600,000 people in those studies in the last 5 years, all using iPhones. After they got a hold of it, again, because it's open source, they can improve it. This is what it looks like post-Apple, where you have a navigation, you have a very structured area. We have this concept of an on-task picture, headline, and subheadline, which they've made much prettier. This is quantitatively shown to slow the eye gaze down to the same speed as print when you do eye gaze fixation tracking. Also, when you do reading comprehension timing, it slows people down to the same speed at which they read in print. Going past that, Apple baked this into their technical framework so that it's not simply something that they sort of recommend, it's part of their required workflow for building a research app. All the way through to the directions to the programmers, because I can tell you most programmers don't care about informed consent, the Belmont report, or any of these other things. They want engagement and users. And so having this now propagate all the way through into the largest lifestyle company in the world is a pretty remarkable success story for federal funding. This has kept on going and is paying off again. So as part of the 2016 extension of the Obama Precision Medicine Initiative into the All of Us research program, which is a much more complex study. It doesn't aim to just use sensors to get at whether you're walking correctly or not. It aims to pull in environmental, social determinants of health, biological and clinical data, and behavioral data into a 10-year study of 1 million American residents, at least half of whom must come from ethnic and racial minorities, and with a mandate to involve at least 75% of the million traditionally underrepresented in research across a variety of demographic variables. So blood, urine, longitudinal health records, genome sequences, linked data from census, air quality, everything you can imagine as part of this study to be made as publicly available as possible while keeping the participants safe. We were awarded the contract to develop the informed consent for this project based on the AHRQ work. And this is the sort of thing that wouldn't have existed under a traditional, we're going to investigate and write a paper about why consent's broken. This is what that project looks like now. It's too complex for the version that we built. We have to have videos that outline all of this key information. This allows us to immediately layer translations over the animations. So we've already launched this in Spanish, and we're now launching in another 7 languages over the next 3 years. All right, there's this whole process where this structured design sort of concept for consent that came out of this very, very small, very unusual and kind of edgy this. And if I had time, I would show you screen after screen after screen that shows that it works. So we don't really know what informedness is in informed consent. We mainly know it by its absence in most of what we do. So this is over 180,000 people who have consented into the All of Us research program. Just a basic question is what we call therapeutic misconception. It's a key problem in informed consent. People think that the research study is treatment. It's a classic mistake. Most of the review papers show that on average, a traditional consent process gets you 40% accuracy on this question. As you see here, we're in the 90% accuracy on this question. This is showing it across education. So you see a very mild gradient. But again, the worst of these are in the low 90s, the best are in the high 90s. We see these numbers propagate across all the questions we ask as part of consent, across all ethnicities, ages, income levels, education levels. Every demographic we can get at shows that if you spend the time to talk to people and design for them to be informed about choices, they understand it. But it takes a design process, and that's the sort of thing that healthcare research and quality investment leads to, but biological research doesn't. And venture capital doesn't fill this hole. Traditional funding streams don't fill these holes. They don't let us research a product that implements a policy and then see if it works or not, and then give it away so that it can grow. So just one quick story of what AHRQ can do that other agencies can't do, and the impacts that that has had. Thank you.